So, think about this for a second. What actually happens when the human body's largest organ, our skin, is suddenly and severely destroyed? A major burn isn't just some nasty surface injury, right? It's a massive, system-wide shock that literally threatens every single physiological process keeping a person alive. How exactly does a medical team pull someone back from the brink when the very shield protecting them from the outside world is just gone?
Well, let's dive right into this explainer and demystify the intensely complex, multidisciplinary process of managing severe burn trauma. We're going to break down this incredible timeline of survival, starting from the critical first seconds of the injury all the way through to the months and years of rehabilitation.
To really get a grip on this, we'll map the journey out into 5 distinct phases: pre-hospital first aid, acute hospital assessment, calculating burn depth and fluids, surgical wound management, and finally, long-term recovery.
Let's kick things off with Phase 1, pre-hospital first aid, also known as stopping the clock. Those very first moments right after a fire, they dictate absolutely everything that follows. Fast, effective first aid is the name of the game here. Once you know the rescuer is safe and the burning process is totally stopped, the absolute key is cooling that burn down. Now, you might be wondering, why use tepid 15 degrees Celsius water for 20 minutes? Well, cooling it down actually slows the delayed microvascular damage that keeps happening even after the heat source is gone. But it's a super delicate balancing act. We have to walk a tightrope to avoid dropping the patient into hypothermia, because that is incredibly dangerous for trauma victims. After that, checking the standard ABCs, airway, breathing, and circulation, giving oxygen for any potential smoke inhalation, and elevating the limbs to fight massive swelling, well, that rounds out the critical first response.
All right, moving right along to Phase 2, acute hospital assessment or the emergency department protocol.
As soon as that patient hits the ER doors, the trauma team immediately kicks into this highly structured clinical strategy. It brilliantly illustrates the Advanced Trauma Life Support, or ATLS principles. Think of it as a strict alphabetical checklist, A, B, C, D, E, F, where securing the airway and starting fluid resuscitation are the absolute top priorities. Seriously, you literally cannot get distracted by the burn itself until these fundamental, life-sustaining parameters are totally locked down.
Now, the reality of securing a burned airway is frankly terrifying. When someone inhales superheated smoke, their airway can literally swell shut. But here's the really tricky part. The clinical signs of respiratory failure, like struggling to breathe or dropping oxygen levels, they might not happen right away. It can actually take up to 5 full days for that lung injury to fully reveal itself. So being proactive about airway protection and intubation? Absolutely a lifesaver.
The main takeaway right now is that every single intervention the team is doing is designed to avoid one terrifying concept: the lethal triad of trauma. This is a deadly, compounding downward spiral of hypothermia, high blood acidity, and the blood's inability to clot properly. So, when you see a medical team pumping warmed IV fluids or literally cranking up the thermostat in the trauma bay, they are actively fighting off this triad just to keep the patient viable for surgery.
Next up is Phase 3, burn depth and fluids, or calculating the damage. Once we've got the patient stabilized, the team has to urgently calculate just how big and how deep the burn is. Why? Because massive burns cause massive fluid loss, and we need to know exactly how much fluid to pump back into their system. There's an incredible clinical trick for this called the rule of palms. Basically, the surface area from a patient's wrist crease up to their fingertips equals exactly 1% of their total body surface area. This neat little trick allows emergency responders to make super rapid, incredibly vital field estimates just by comparing the patient's own hand size to their burns.
Now, that surface area calculation builds the entire treatment plan by dividing burns into 2 very distinct camps. Group A burns are superficial. Sure, they're super painful and they blister, but they'll generally heal on their own within a couple of weeks without needing surgery. Group B burns, on the other hand, are deep. They damage the full thickness of the skin, often feeling kind of leathery. Because the nerve endings are destroyed, they actually lack sensation. These are the ones that absolutely will not heal properly on their own. They strictly require the surgeon's scalpel.
You can clearly see a classic Group A burn here. Notice those big blisters and that pink, moist base underneath? For a patient with this type of burn, the team's goal is mostly supportive. We're talking aggressive pain management, careful dressing changes, and above all else, preventing a secondary infection. If this wound gets infected, it can actually deepen and cross over into a Group B burn, which complicates the whole shebang. And that brings us to Phase 4, surgical wound management, also known as the race for coverage.
For those deeper Group B burns, we can't just wait around. That slow, natural course of healing has to be actively interrupted. See, the dead, burned tissue, which we call the eschar, causes massive inflammatory fluid shifts, and it's basically a breeding ground for bacteria. Getting rid of it is absolutely crucial. But surgically excising this tissue is a huge physiological hit to the body. It really is a rapid race against the clock. The anesthesist has to be incredibly vigilant here, strictly keeping the core temperature above 36 degrees Celsius and prepping for severe blood loss. They have to keep the patient's physiology perfectly balanced while the surgeon urgently clears away the damage.
Once all that dead tissue is gone, the patient desperately needs a new protective barrier. This before and after progression is just incredibly satisfying to see. On one side, you've got the raw, surgically excised dermis, and then on the other, that exact same area has been meticulously covered with a split-skin autograft, which is just healthy skin taken from another part of the patient's own body, and it's fixed securely in place with surgical staples. Boom. This provides the stable, life-saving coverage the body was basically screaming for.
Finally, we reach our last phase, long-term recovery, focusing on the human element.
Making it out of the operating theater is honestly just the beginning of a relentless, multidisciplinary climb back to a normal life. Just look at this timeline. Because massive burns send the body into an extreme catabolic state, meaning it's essentially consuming itself for energy, super aggressive nutrition via a feeding tube has to start within just 6 hours of the injury. By day 1, physical therapy kicks in to fight off severe joint stiffness. And for up to a year and a half, patients have to wear these incredibly tight pressure garments constantly to prevent scar hypertrophy, which is the severe thickening of the healing skin. But navigating this grueling timeline requires way more than just clinical steps. The medical team has to consistently communicate and counsel the patients and their families. They have to manage expectations about the final outcome and this brutal rehab process with deep empathy and care, helping them adapt to a completely new, often really difficult reality.
We really can't ever forget the profound psychological trauma of this journey. As this quote perfectly captures, a major burn is an overwhelming, world-altering event that shatters a person's sense of safety. So intense clinical psychology interventions are just as vital as the physical skin grafts. This is where compassionate counseling becomes absolutely paramount. Healthcare providers have to demonstrate immense empathy, validating all the patient's fears and celebrating every single small victory. Because at the end of the day, rebuilding a patient's shattered sense of safety is just as crucial as repairing their skin.
Now, as that skin finally heals over the coming months, it has this stubborn, frustrating tendency to shrink and contract, which can literally freeze up joints. To fix this, surgeons use some really elegant reconstructive techniques like the Z-plasty procedure. By making these super precise mathematical cuts in the scar tissue, they can actually unlock those tight bands, reorient the tension lines, and beautifully restore the patient's full range of motion. It's basically structural engineering on human skin.
When you step back and look at this entire staggering process, from rapid cooling out in the field to meticulous scar release surgeries years later, it really makes you wonder, what kind of future breakthroughs are going to make this miraculous timeline of survival even more successful? How far will next-generation skin substitutes and personalized medicine let us push the incredible limits of the human body to heal? I really hope this explainer has given you a profound appreciation for both the fragility and the absolute astonishing resilience of the human body, as well as the deeply dedicated teams who fight so hard to save it.